Welcome to ICU Primary Prepcast.
Hi, I'm Maddie.
Hi, I'm Swapnil. And as usual, we are joined by our third host, Dr. Mike Clifford from Melbourne. Welcome, Mike.
Welcome. Thank you very much, guys. Good to be here.
Yeah, first of all, Happy New Year to all listeners and Happy New Year, Maddie and Mike. I'm pretty sure that's not the start that we expected for 2022. Any particular plans for 2022, Mike and Maddie?
I'd like to go to New York to see my sister, but we'll see how the year pans out.
Yeah, I don't have any specific plans this year. I've got one kid going off to university and I've got my last one making his way through a secondary school. So I think we'll just be battening down the hatches and hope we don't end up furloughed too often.
That's right. And my plan is to make a plan. So we'll see how it goes. So today we are going to discuss another patient in ICU. So I guess, Mike, you got a scenario for Maddie?
Yes. Okay. Well, we've got an elderly lady who's been admitted with septic shock. We think it's urosepsis at this stage. So she's 82 and she's recently moved from her assisted accommodation into a nursing home. But at the moment, she's has a full resuscitation status. Those conversations haven't yet been had with her family. At the moment, her problem is one of hypotension. She's got systolics in the low 80s. And I was wondering if you could take us through some of the issues related to the cardiorespiratory changes of being an elderly patient.
So I think we'll start first with the cardiovascular changes, and these can be thought of for her in terms of the myocardial changes itself and then the vasculature changes. In terms of the myocardial changes, first of all, structurally, she's more likely to have centric ventricular hypertrophy, which causes an increase in her cardiac size. The myocytes themselves hypertrophy, but there's a decrease in the myocyte number, and she's more prone to have an increase in atrial size, which can also predispose her to atrial fibrillation. There's also an increase in valvular circumference for all the valves, predisposing to valvular disease. And then the shape of the heart itself changes from more an elliptical space to a more spherical shape. And there's an increase in the intraventricular septum more so than the free wall itself. In terms of the systolic and diastolic function, the systolic function doesn't generally change, but there's a decrease in the diastolic compliance and ventricular filling, especially in the early or the passive diastolic phase. Therefore, because ventricular filling is more reliant on the later or active filling, it becomes more reliant on the atrial kick or the atrial contraction for filling. So if patients develop atrial fibrillation, they're more likely to have a compromise in their cardiac output as they get more elderly. So from the cardiac output perspective, there's a general decrease in the cardiac output and an increase in the left ventricular afterload. If we're thinking about her conduction system, there's an increased fat accumulation around the sinoatrial node and a decrease in the number of pacemaker cells. And there's on an ECG, there's generally an increase in the PR interval and a leftward QRS shift. And from an autonomic and responsiveness perspective, there's a decreased number of autonomic receptors and density, and therefore there's a decreased sensitivity to catecholamines, which can be important when we're thinking about giving someone inotropes, such as in this case when she's shocked. Elderly people like this lady also have a decrease in their maximum heart rate, so they're more reliant on their vascular tone and their preload to maintain blood pressure. And there's a decrease in maximum ejection fraction during exercise and an impairment in the baroreceptor reflex, predisposing to things like vasovagals and syncope. And from a vascular perspective, there's an increased diameter of the aortic root, which happens as we age, and a decreased amount of nitric oxide release. And there's a thickening of the intima and the media of the vasculature, which increases the total peripheral resistance and increases pulse pressure and the mean arterial pressure. And as a result, elderly people are more prone to conditions such as hypertension. If we're thinking about her respiratory function, we can think about this in terms of the respiratory mechanics, firstly. So she will have decreased chest wall compliance because of increased calcification, mainly around the ribs and the sternum. And there's a loss of elasticity in the lung tissues and airways with increased lung compliance and increased closing capacity, which would predispose her to small airway closure and an increased risk of gas trapping. And her muscle strength decreases. So there's a loss of muscle mass of diaphragm and intercostals, making her more prone to respiratory fatigue. From an airway perspective, there's a slowing of the ciliary escalator, which is a mechanism we use to get rid of foreign substances that may irritate the airway. And there's an impaired cough mechanism, which would make her more predisposed to things like aspiration, and an impaired pharyngeal function. From a respiratory volume perspective, she'll have a reductions in her FEV1 and vital capacity, mainly due to an increased chest wall rigidity and loss of respiratory muscle strength, and a reduction in her maximal rate of oxygen consumption. But there'll be a higher residual volume and a higher FRC. She'd also have an increased dead space because the cartilaginous rings that hold the upper airways open calcify. So there's an increased diameter of larger airways, especially the trachea and bronchi. From a gas exchange point of view, she'd have increased VQ mismatch and increased alveolar capillary membrane thickness, which means a decreased diffusing capacity for carbon monoxide. Also, the alveoli ducts dilate and disintegrate, so she'll have decreased total alveolar surface area and have a reduction in her baseline PaO2, which would make her more susceptible to hypoxemia, which is important, especially if she has things like respiratory sepsis. And from a ventilatory control perspective, she'd have a baseline increased work of breathing and a diminished ventilatory response to hypoxemia and hypercapnia, and a decreased number of macrophages, but an increased pro-inflammatory neutrophils within the airways itself, making the airways more responsive and making her more predisposed to bronchospasm. And the final thing that happens is there's an increased pulmonary artery pressure in the absence of pathological states. So there's a lot of things that will happen to her cardio and respiratory function as a physiological part of aging that will impact on our treatment of her within the ICU.
Excellent.
So I think as we've just talked about some of the physiological changes, Mike, can you tell me a bit about some of the pharmacokinetic and pharmacodynamic changes that might happen in this lady as she's elderly?
Yeah, okay. I mean, you've alluded to some of them, haven't you? You've described some receptor sensitivity changes related to catecholamine therapy, and you've described some changes in her body mass composition. And that's really sets up the field nicely of this sort of pharmacological question. There's surprisingly very little about this in the pharmacological textbooks. They don't have a section on the elderly. They often have a section on neonates, but they don't have a section on the elderly. But there are some fairly big changes because increasingly calendar age is not felt to be particularly helpful when looking at an elderly patient, and the concept of frailty is increasingly important for geriatric medicine and in ICU, and looking at the frail elderly patient as opposed to just the elderly patient. But there are a few things that we can predict. So aging, we know, is associated with a reduction in the number of receptor responsivity in all systems, and particularly in the brain, where there's a reduction in synapses and reduction in cross-brain signalling, which would suggest an increased sensitivity to sort of anaesthetic and sedative type agents, which we know occurs and which we see. So the way to approach this question is, like any pharmacology question, you divide up into pharmaceutics, pharmacokinetics, pharmacodynamics. The pharmaceutics you would think would not matter, but in fact the elderly have a reduction in the gastric acidity, and they have impairment in gastric emptying and slowing of gastric emptying and slowing of small and large bowel migration complexes. So all of the oral absorption of their drugs is impaired. We haven't looked much at the differences between sex in terms of pharmacoceutics and absorption, but in fact, increasingly people are documenting differences in how females absorb different drugs and different compounds, differences between generic and non-generic medicine. And so there is so much we just don't know, because almost all of our pharmacology is based on observational and trial data in the typical male 20 to 50. So the rest of the population doesn't exist as far as they're concerned. And it's post-marketing surveillance that provides us with information on the other group, of which the elderly forms a significant number. If we think about pharmacokinetics, that's the usual absorption, distribution, elimination, metabolism. That's probably where the key information is, certainly if you're going to write a short answer question. So we've alluded to some of the absorption changes, the reduction in gastric and small bowel transit. There's a reduction in small bowel surface area. The number of Hausdorff and villi and microvilli are reduced. Mesenteric blood flow is also reduced, so your capacity to absorb blood into the portal system is reduced. But then your volumes of distribution are actually quite different. So the elderly person, and particularly the frail elderly, which I alluded to by telling her that she's just gone into a nursing home, is that they have a reduction in their body water content, and the numbers vary, but around about 20 to 30%. You've got an increase in body fat content by about the same amount, 30%, and decreased muscle mass by about 30%. So if you think about 30% for all of them, you'll be roughly right, and that's probably accurate enough for the exam. So that alters your volume of distribution. So particularly for water or fat-soluble drugs, you can imagine if you've got less water, less vascular space, your bolus dose will have a much higher concentration. So that one of the things to think about for almost all the drugs we give to the elderly is a reduction of the bolus initially. And then if they're with that reduction in water solubility, you may not need as much drug to maintain that concentration in the water-soluble space. But they will have increased absorption into the fat storage system, so they'll have a prolonged excretion, particularly for fat-soluble drugs. And that's a lot of the drugs that we use in ICU. So, our benzodiazepines and our opiates, ketamine, propofol, all of those drugs, you can anticipate that if you give an initial bolus, you should reduce that bolus dose. And again, rough rule of thumb, between 30 and 50%. And your maintenance infusion rates should also be reduced by approximately that amount. And one thing we know from auditing adult intensive care units is almost always we don't reduce the maintenance infusion rates of those drugs. So we are probably overdosing most of our elderly patients and contributing to some of their systemic side effects, and cardiovascular ones would be a big one, but also respiratory. And similarly, we are increasing the side effects that we see with those drugs, not least of which is prolonging their problems with delirium from the central nervous system activity. So those are the sort of pharmacodynamic effects. We know that there's a reduction in renal mass over time, and therefore your renal clearance will be reduced. So drugs that are renally cleared, you should think about how you're going to reduce some of those drugs in the setting of a frail elderly patient. And similarly, the hepatic biotransformation is reduced. So if you're giving a pro-drug, you can anticipate that there'll be less active drug for a given amount of time, and that you may see a slowing of the metabolism of those drugs that require biotransformation in the liver also. The pharmacodynamic effects, depending on the class of the drug that you're giving, but those drugs we give where we're reliant on body systems to optimize the response, you can anticipate that they may get less effect. So paradoxically, we're going to give less propofol initially and less over time, but we're going to get more effect in the brain because there's increasing sensitivity in the brain to those drugs. But something like the cardiovascular system, where you've got marked reduction in sort of beta-adrenergic activity, you may need to give a higher dose, say, of catecholamines for an equivalent level of responsivity. And I think one of the beauties of ICU is that we always give a little bit, and then we can give a little bit more, and we titrate most of our drug therapy to response. So that, I think, protects us a little bit, certainly for a patient like this where we're looking at sepsis. But, we're going to choose an antibiotic for this little old lady, and we need to consider the initial dose and then the maintenance dosing that we're going to give. We're going to treat her with an agent to protect her blood pressure. And if we subsequently intubate her and ventilate her, we're going to need to consider the sort of agents we're going to choose to initiate and maintain sedation. So all of those decisions will be informed by some of our basic understanding of the changes of the elderly patient. And I would certainly want to have a ward pharmacist on my ward round who can tell me which of the many drugs we're giving are going to interact. And that's not even considering all of the drugs that this person came into hospital on, most of which we could probably stop, but some of which we can't, and trying to anticipate which of those drugs are going to interact with the ones we're going to give is very complicated. So I am very glad that I look after children who often have one system issue, and they respond almost normally like little adults, which makes me very happy. Unfortunately, we've got to the stage where this little old lady has survived our somewhat lackadaisical pharmacological therapies, but as anticipated, at the other end, she's having issues with delirium. And we're going to now have a look at how we might manage some of that delirium. We've done all of the usual housekeeping things. We've got a day-night cycle. She's got family sitting by the bedside as much as we possibly can, and she's being reoriented. But she's still periodically quite agitated, and the team feels that she does require some sort of pharmacological restraint. I was wondering if you could take me through some of the common drugs we would use in that setting.
Yeah, that's correct, Mike. It's not a very uncommon problem in ICU, and often the understanding of antipsychotic medications or anti-delirium medications in intensive care is quite limited. One of the most commonly used medication in intensive care unit, especially in adult world, is haloperidol. And although it's some predominantly antipsychotic medication, which is used predominantly in schizophrenia, it has been increasingly used in the intensive care unit to manage the hyperactive delirium. Now, just a little bit of pharmacology of haloperidol, because it has not been asked in the past in exams, so it might be asked in future. It's a high potency first generation or the typical antipsychotic medication, and one of the most frequently used antipsychotic medication worldwide. Now, the main mechanism of action is a strong antagonism at D2 receptor or dopamine receptor, particularly within the mesolimbic and mesocortical system of the brain. Now, it has been indicated in various diseases, so mainly the schizophrenia, acute psychosis, Tourette syndrome, behavioral disorders, but also it can be used as off-label in the management of intractable hiccups in intensive care unit and also for the delirium. Now, often there is a contention about the dose that we use in intensive care unit, and especially when you speak to psychiatrists, they almost get seizures when we tell them the amount of dose that we use in intensive care unit. So understanding the pharmacology is very important. So I guess the reason haloperidol is used in hyperactive delirium is mainly because it's quite effective in management of the positive symptoms of schizophrenia, which include hallucinations, hearing voices, aggression, hostility, which we often see in our patients in intensive care unit because they are in an unfamiliar environment and they start seeing things. And that's why haloperidol works better especially in hyperactive delirium. Obviously, it doesn't work much in hypoactive delirium. And amongst the first line or typical antipsychotics, it's probably the most kind of safe drug compared to chlorpromazine or some of the other agents. Now, coming back to its pharmacodynamics, as I said, it mainly acts on the positive symptoms, which are psychosis or hallucinations. Coming back to its pharmacokinetics, absorption, it is very highly lipophilic compound. It is normally orally administered, but also can be given intramuscularly or intravenously. Usually, when you give oral haloperidol, it takes roughly around like anywhere between 1.5 hours to 6 hours to act or to reach its peak concentration. While when you give intramuscularly, the peak concentration reaches within 20 minutes. And with IV administration, it reaches less than 10 minutes. And that's why sometimes in intensive care unit, I'll prefer to use intravenously. Now, in terms of volume of distribution, it has got a very high volume of distribution purely because it's very lipophilic compound. And obviously that helps to cross the blood-brain barrier. In terms of the protein binding, it has got a very minimal protein binding. It's only 7 to 10% drug is protein bound. And in terms of the metabolism, as I mentioned before, it extensively metabolized in liver and only less than 1% is excreted unchanged in the urine. Now, because it is metabolized in the liver via cytochrome P450 mechanism, it has got a potential interactions with the other medications which are also metabolized by the cytochrome P450 mechanism. In terms of coming back to its side effects, has got a lot of significant side effects that one should be aware of. That mainly includes extrapyramidal symptoms, disorders such as akathisia, tardive dyskinesia, but also it has got a risk of increased QT prolongation and sudden death and leading to torsades de pontis. And other fatal symptoms that can result from haloperidol toxicity includes neuroleptic malignant syndrome, which is characterized by hyperpyrexia, muscle rigidity, and altered mental status. So obviously, when you prescribe haloperidol, you need to be careful and obviously keep eye on QT prolongation, keep eye on the development of neuroleptic malignant syndromes.
What sort of dose do you use, Swapnil?
So usually the recommended dose is, if you are going to give IV, usually 0.5 to 1 milligram IV. And again, as you said, titrate it to the effect. So gentle boluses and then make sure, especially in the elderly, haloperidol is again not one of the most favored drug because of the high lipophilicity and prolonged effect. And if you are planning to give it, make sure that you titrate it to the effect.
Okay.
The other medication that commonly asked is Olanzapine, which is again increasingly used in ICU nowadays because of its atypical antipsychotic medication and are now classified as a second generation antipsychotic medication. And the way it differs from haloperidol, it's mainly the mechanism because it's not just a D2 receptor antagonist, but it also acts on the serotonin receptor. And so, as I mentioned, the dopamine receptor antagonism lead to decrease in hallucination, delusions, and disorganized speech, while the serotonin effects lead to prevent the onset of anhedonia, flat affect, volition, or poor attention. So Olanzapine has got a bit of tendency to act even in hypoactive delirium along with hyperactive delirium. So it can work across both spectrum of the delirium compared to haloperidol. And also due to its effect on dopaminergic receptors and also serotonin receptor, it can be again used as anti-emetic agent, especially with the chemotherapy-induced nausea vomiting. Pharmacokinetic profile is similar. Again, it's a very highly lipophilic drug. Volume of distribution is quite high, up to 1,000 liters. Different to haloperidol, it's more protein bound. Almost 93% is protein bound. And this is also metabolized in liver via cytochrome P450 system. So again, it has got a potential to interact with other medications. And route of elimination, although hepatically metabolized, almost 53% is excreted via kidneys unchanged. And the half-life is usually anywhere between 20 to 50 hours. So again, make sure that when you administer olanzapine, it has got a long half-life. The dose we usually use in elderly is around 2.5 milligram wafers. Just put under the tongue, much easy. You can't give olanzapine IV. So that's the kind of difference between the haloperidol and olanzapine, especially when the patient is extremely agitated and you need to get something in quickly. Obviously, you can't.
It's interesting stuff there too, isn't it? I mean, there aren't many drugs we can give sublingually or in the mouth. So what are the benefits of giving drugs into the oral cavity?
So I guess the absorption is quicker and also much easy to administer, because a lot of these patients will have some sort of dysphagia or swallowing abnormalities, and then you can't really crush tablets. So just putting a sublingual with a high absorption gives you quicker effect. And one of the side effects of olanzapine is actually somnolence, mydriasis. So sometimes you do see dilated pupils after olanzapine, then blurred vision, respiratory depression, hypotension, and all the other extrapyramidal symptoms, along with some anticholinergic effects. So these are the kind of two commonly used drugs.
Just to finish off that little point, the benefit of drugs that are absorbed buccally or sublingually is that you avoid first pass metabolism.
Yeah.
So you can get more rapid onset and higher drug levels. That's one of the reasons why buccal midazolam was used for many years to treat epilepsy. Is that you trickle it into the cheek while they're fitting, try not to get your fingers bitten, and you would get fairly rapid seizure control. So that's one of the nice things about olanzapine. If you can get it into the mouth and it absorbs across the cheek, you get a reasonably rapid onset of drug effect.
Yeah, no, that's correct. And I guess coming back to the medications in elderly, I guess even other antipsychotic agents such as quetiapine or risperidone, they all are obviously, they come with their own side effects. Again, there is no right or wrong answer as long as you understand the pharmacology of each drug and know how much to prescribe and not to cause overdose. Or if you are treating, make sure that you are monitoring for its side effects. That's the main thing. So I guess that's the end of the clinical component of today's podcast. Now there's a fun component.
Anytime.
Okay, this one Jules, my husband, came up with when we were talking about some of this physiology. So why did the elderly tourist feel short of breath when visiting Egypt?
Is it in denial? No. Denial?
Oh, close. They were in denial. Very good.
Well, it is close, but because of his senile emphysema. I know we don't use that term anymore, but
senile emphysema.
Yeah.
Did he write that himself, Maddie?
He did. He came up with that.
Has all the hallmarks of a homegrown joke.
It does, doesn't it?
Okay, so just to remind everyone, I think the scores, we just started again this year. So I guess Maddie is leading by 4-3.
Maddie's husband's on the board now.
Well, we're a team. So
you're a team. Okay, okay.
So, but at least I was close this time, so I should get half point for this.
I know, you're learning, I think.
That's right. Yeah. You're picking it up from
thanks, Mike, and thanks, Maddie, and thanks, listeners. We'll obviously continue our monthly episodes even in 2022. So look forward to seeing you all next month. Till then, stay safe and goodbye.
Excellent. See you later, everybody.
Thanks for listening.